Did everyone have a good weekend to recoup from Friday? Hopefully. Okay. All right, so it's 9:30. I can officially begin. First thing is the exam. Obviously, I posted the scores. Our first exam average was 75.9, which is actually really good. If you got, you're going to get your Scantrons back in lab this week. I'll bring a collapsible folder and all that stuff. Anyone who got 40 out of 50 questions and up, right, you're doing okay. Because that was the hardest exam of the semester because of all the pathways. And this is probably the first time you've encountered pathways, okay? We had the metabolism chapter, and then we had acetylcholine signaling in its receptors, okay? So that was a challenge because it's a new way of being presented information and learning how to study it. Now that you've got that down, when we have pathways again, like we get to the endocrine chapter, it's another pathway, but I hope, and from those scores, you're kind of getting it, all right? If you're using the practice flow diagrams and everything, and you paid attention to the email I sent out with the exam breakdown, you were good. Now, if you got like 35 or lower out of 50, this is a time to come talk to me. We can discuss how you're studying, how you're preparing. We can, when you have your Scantrons, I'll bring the exam key to lab so you can compare. Because when you look at the types of questions that you got wrong, there might be a pattern that you can identify. And you say, oh, I second guess myself, darn it. Well, then you'll learn not to do that. If you said, I just didn't study that chapter well enough, then you'll know that was it. Things like that, okay? But I was pretty happy for a first exam average, really did well. There were 2 perfect scores. It can be done, all right? So I do wanna encourage you. We do have today in lab, we're here, make it a little bit bigger. We got the sensory lab, we got a quiz at the beginning, so don't forget to print that handout out with enough time to review it. And really, you want to definitely pay attention to everything on this first page. You kind of want to look at mechanoreceptors, but you want to know the difference between mechanoreceptors, thermoreceptors, noisy receptors, which are pain receptors, and then how much of all this stuff. I'm not going to ask adaptive response. You'll want to look a little bit over photoreceptors. I mean, I assume you had this from anatomy, but just look that over a little bit. And then I'm not going to ask those. Not that. So basically, definitely look over photoreceptors, which is there. And then everything on the first page and a little bit about thermoreceptors, what they are. And basically that stuff that's on the first page. Okay. That is one thing we skipped when we were covering the peripheral nervous system, which I might get back to because I'm going to get back to the last chapter 4, part 3, go over that stuff. And so by me going over it, it'll help you guys for the quiz and lab, you'll have it down, right? Right, because I skipped it because I wanted to focus on acetylcholine signaling. Okay, so let me go back to, I don't think I need any of that. No. Okay, so we left off here. I am going to back up a little bit, okay, to what I skipped. There we go. And I don't want. All right, so we left off with this because we were talking about acetylcholine signaling, which was on the exam. And was it exactly what I told you? Matching, description of a body regulation under rest and digest, and then the receptors on the right-hand side. I told you exactly what was coming. Okay, so and then we talked about sympathetic effects. Now what I'm going to do is I'm going to back up, way up to this. And the reason I'm doing this is because of today's lab quiz. So I do try and prepare you. So we skipped this part. Oh, go back. We skipped this part right here. Come on, pen. How the peripheral nervous system sends information up the spinal cord. This is the ascending pathway or the sensory pathway. Ascending or sensory pathway. I'll say sensory, NS, which is sensory nervous system, which is what you're testing in lab today, at least part of it. Okay, so what we've got are 3 divisions of the sensory nervous system, and that's what that first page of your handout for lab is. So you've got, the first one is somatic sensory division. Okay, it involves mechanoreceptors thermoreceptors. These are things you have throughout your body. And nociceptors, which is for detecting pain. The mechanothermal is for temp. That's what thermo means. Now, the mechanoreceptors are for feedback on or feedback from, spelling wrong on Monday morning, from skin, joints, muscles, and I'll write it down here so you can see it. Fascia. Fascia is that connective tissue that holds your skin to your muscles and connects body organs and things like that. But it's things that are found throughout your whole body. So mechanoreceptors we're going to test today, they're found in your skin. In fact, all of these receptors, mechanoreceptors, thermoreceptors, pain receptors, those are all in your skin. And we're doing a 2-point touch discrimination test. And it is a real test to see if someone's got a sensory deficit on a certain part of their body. Like, let's say they got in an accident and the dorsal part of their spinal cord, which would handle sensory perception in their torso and arms, was damaged. And that's a test a nurse would do to see how well can you feel this stimulus I'm giving you. Thermoreceptors, we're going to have you put your hands in some different temperature water baths, really cold versus really hot, and you're going to notice adaptive. You adapt to a temperature. We're not testing pain receptors because that's not reasonable to do to students in a lab. But we are looking at in lab feedback from your skin, and believe it or not, feedback from our joints when we do the balance test. So we are testing some of those somatic sensory receptors. Then you'll have visceral sensory. What does the word viscera mean? Your organs. All right, so it's sensory feedback from your organs. So your internal organs. That would include things like the aortic arch and carotid arteries. Remember, we have sensory receptors there that detect blood pressure. That's what we're talking about. Your heart itself will has sensory receptors in its chambers. We'll cover that much later. Your bladder has sensory receptors for stretch. And when your bladder is full, you get the urge to urinate. The stomach has stretch receptors. So when it's full, you get the feedback of, oh, it's time to stop eating. The cervix in childbirth has stretch receptors. That's an organ. And remember we talked about oxytocin and positive feedback? So that's visceral sensory. Now the last part, now we're not able to test those, but there is special senses. So when you think about special senses, really think about sight, which we are testing in lab, sound, which we are testing in lab, and taste, which we already tested. We already tested that when we did the taste lab. So those are your special senses. I mean, there's some more in there, but that's the basic idea. Okay. So by me going over this right here, all right, that is some of the questions on today's quiz is going to involve those things. So I want to make sure and go back to it and go over it. So that's what you want to focus on. Okay. All right. So I will definitely post these notes when I'm done with lecture today. I'll try and get them up before lab if you just want this. But if you remember, on the blank flow diagram and the key, which if you click here, I do have it all there, okay? So if you look at the key, what I just wrote down, in fact, I wrote down a little bit more than what's here, but that will be there. But so on the first page of your handout for today, it's written down, not in the diagram format. All right, so I don't think I need that now. So let's go back and get where we were, which is much farther. So now this is done, done. But peripheral nervous system physiology, which is what this chapter is. Our next lecture quiz, which I can't remember off the top of my head, but it's on the syllabus, will be knowing epinephrine and the beta-1 adrenergic receptor, beta-2 adrenergic receptor, and the alpha adrenergic receptor, okay? You'll want to know that. And so you'll be going back to these notes for just the sympathetic stuff. Now, we covered this, but this is what I didn't get to because it wasn't important because it wasn't on the exam. This will be on the next lecture quiz though, because epinephrine signaling and its receptors, just as important in nursing. And they're going to want you to know these things. And the drugs they give you examples of that act as agonists or blockers are some of the most commonly prescribed drugs to treat hypertension, asthma, cardiac failure, things like that. All right. And you will learn them and many more in pharmacology. So focusing just on this stuff right here. Okay. So this is not a table that's in your textbook. It's just one from a textbook I used to use and I just kept it. So sympathetic, selected adrenergic effects for epinephrine. All right. So this you'll want to learn for the next lecture quiz. All right, so if we start with, and I crossed out stuff, there's always more information to learn, but I cut a lot of stuff because I know you're being introduced to this stuff for the first time, so I already feel like I overwhelm you, but I try not to, so I cut a lot of stuff. So the heart, you know that in a fight-flight response, heart rate goes up. That makes sense. Your life is in danger. All right, so the heart rate goes up, and the epinephrine will be binding to the beta-1 adrenergic receptor. Please note they say primarily because there's other receptors, but I'm not going there. Okay, it's too much right now. But beta-1, all right, one heart. Now, GI visceral vessels, arteries going to the gut. It's fight flight. Digestion is not going to save you. The body doesn't want to waste blood supply, oxygen and glucose on an organ that's not going to save you. So you shut it down. So epinephrine binds to its alpha apple adrenergic receptor and it shuts down that blood supply. You get arteries constrict or vasoconstriction. Okay, not in order the way I go over it, but anyway, skeletal muscle vessels, arteries. All right, arteries dilate due to epinephrine binding to beta-2 adrenergic receptor. Best to get away. Your skeletal muscles are going to need a good blood supply to allow you to fight or fly, run away. Lungs, all right, bronchioles, got 2 lungs. They're going to dilate the bronchioles because of beta-2 adrenergic receptor binding. And then lastly, back to stomach stuff, stomach and intestine, okay? All you need to know is this, slows the passage of food. Shut it down. Shut down peristalsis, shut down glandular secretions. And we already talked about how the arteries constrict. But look, alpha adrenergic receptor. So when I ask you these questions, similar to the way I ask for acetylcholine signaling on the exam, it'd be very similar for the lecture quiz. I'll have an autonomic body function during fight flight listed on the left. But now I'll have all the receptors I did before, nicotinic cholinergic, muscarinic cholinergic, beta-2 adrenergic, beta-1 adrenergic, alpha adrenergic, 5, okay? You now have to select from the adrenergic receptors. If I'm saying fight flight question, it's not acetylcholine. Immediately cross off exam strategy. Any cholinergic receptor, that ain't it. It's got to be an adrenergic receptor for adrenaline or epinephrine. Now, how many people use that strategy that I did teach you to do? Because I said this was coming. I said acetylcholine signaling. It's going to all be rest and digest. I'm going to give you all the receptors I've taught you. If it says adrenergic, cross those off because that's fight flight. That leaves you 2 cholinergic receptors, and one's for voluntary and one's for autonomic. You must. All right. Did that help you guys out? Okay. Because that's the way you take those exams. Okay. Let's move this out of the way because I don't need it now. Now I have maybe put it, I wish I could reduce this, but I have a clinical app online. So if you're looking at this while you're online, it talks to you about drugs that affect adrenergic receptors, either stimulate it, and if I'm waiting for it to come up, or they block it. I'll give it a second. Oh, maybe I didn't hit it. There we go. Okay. Whoop, pretty big, way too big. There we go. Okay, so these are common drugs, and I'm going to give you more than what's on this application. So people with high blood pressure, hypertension, were once treated with a beta blocking drug known as propranolol. It's still on the market. It was one of the first drugs developed that works by this pathway. It's a little cheaper because it's been on the market for so long. So there's a lot of generics. This drug blocks beta 1 receptors on the heart. So epinephrine can't bind to that receptor and can't increase your heart rate. Look at the taste lab. Remember, the T was a blocker to sweet receptors. You coated your mouth with a T for, I don't know how many seconds, waited a couple minutes, and then boom, there's a blocker. It shows you the power of pharmacological drugs. So the heart rate goes down and blood pressure goes down. But as nurses, you're going to have this drug is prescribed for this condition. But here are the contraindications, which means don't give this drug to the person who has these other things going on. Contraindication. This drug is contraindicated for people with asthma or any respiratory problem like COPD or COVID or anything that's straining the respiratory system. Because what the drug will do, it will also block the beta 2 receptors on your bronchioles. So your bronchioles can't dilate, they constrict. And if you've got an asthmatic patient, yeah, you might bring their blood pressure down, but send them into a respiratory crisis. No bueno, okay? Or certainly anyone who had high blood pressure and coronavirus, right? COVID, you wouldn't want to give this drug to them because you could really send them into a crisis. Now, sorry about that share thing, I'll pull it up. Okay, a beta 1 blocker, that's a specific blocker to beta 1 receptor on the heart, will stop epinephrine from binding to that receptor. It'll bring blood pressure down. It does not block the beta 2 receptors on your bronchioles. So if you have a patient that has high blood pressure and asthma, this is the drug to give them because it won't touch their bronchioles. All right. So welcome to Nursing Pharmacology 101. Whatever drug you prescribe, there's probably contraindications, and it's up to you guys to take the good patient history. Bless you. Because if you know, you say, well, you know, we know that your blood pressure is a little high and the diet and exercise part didn't really work well. So we want to consider some pharmacological treatments. Could you tell me some other things? How is your health? All these other things that could be going on. And if they happen to tell you, well, I have high blood pressure. I also have chronic bronchitis and I've got this condition and that condition and that condition. That chronic bronchitis, which is chronic inflammation of the airways, which narrows them. Oh, so you might want to take propranolol because that could cause bronchoconstriction. You already got some of that going on. Right? The doctor's really going to do this, but your patient history, catching that respiratory problem is important to put down on the record so the doctor or PA comes in and they know that, right? Because you spend more time with them. So it will send the doctor in a different direction for the drug because of this patient history. These things are very important, all right? Okay, well, that gives you an idea. Okay, so I'm going to go back to this. Where did my PowerPoint go? There we go. Too many tabs open, just like my brain on a Monday morning. Okay, the beta 1 and beta 2 blocker. It is to treat high blood pressure, all right? It'll bring high blood pressure down by blocking the beta 1 receptor on the heart. Great, but it'll also block beta 2, and that will cause bronchoconstriction. So that drug is called propranolol. Okay, and they've come up with a whole bunch of new drugs, olol drugs, but this is the original. It's still out in the market. Please notice here it says good for hypertension, but not people with respiratory problems, asthma, COVID, COPD, chronic bronchitis, whatever. All right, you will drive them into a respiratory crisis. It'll be bad. So you want to give them beta 1 specific blocker, which is called atenolol. Now it's a beta 1 specific. It won't, no effect on the bronchioles. Okay. So if a person has asthma and high blood pressure, this would be the drug for them. Okay. So it won't cause the bronchoconstriction, but it will block the beta 1 receptor. Now it gets more interesting. Don't write this down. But if you don't dose the patient correctly, according to their body weight, and you give them more atenolol than they need, it'll go off the beta 2 receptor. Welcome to pharmacology. But for you guys, atenolol is the drug, beta 1 specific. Here's how I remember it. Vaccines are attenuated. That means they've been made specific to a particular viral strain. And you've probably read a lot about this because of COVID and things like that. And every year you're supposed to get a new flu vaccine because every year the flu strain is different. It's mutated. We have read about how the COVID virus has mutated. I don't even know. I think we're well past Omicron by this point. I don't even know what the new ones are. I'd have to go and look. The viruses mutate. So you have to make a vaccine specific or attenuated to that strain. So when I think of atenolol, I think of it's been attenuated or made specific to a particular receptor. And that helps me remember the difference between the two. Okay, so those are 2 blockers, and you're going to learn about so many more blockers, but I guess just give the most common one that's out there. Okay, agonists to the beta-1 receptor. So the T act as an agonist, I think for most people to the salt receptor. For some labs, also the sour, but not across the board. But it did seem to be across all 3 lab sections an agonist to the salt receptor, making salt seem more intense. So these drugs go after the receptor. They don't affect how much of the neurotransmitter is there. So a beta-1 agonist, that's called dobutamine, and I like to put up here, makes the heart beat faster. And this is just something I came up with because it helps me remember it. Dobutamine is a drug that is a beta-1 agonist. It stimulates the receptor on the heart. No epinephrine changes. It's just stimulating the receptor. So your heart rate and output of blood from your heart goes up. This is good with people whose heart is not acting as an efficient pump anymore. And the drug kind of helps the heart have a little better output. All right. So their heart rate and blood pressure would go up. All right. So that's dobutamine, makes the heart beat faster. Now, in some cases, you've got someone who's got cardiovascular problems, heart disease, or the heart's an inefficient pump, and also some respiratory problems that they need their airways open. And so that drug is called isoproteronol. All right. So it goes after the beta-1 receptor and stimulates it. So your heart rate goes up, and it causes bronchodilation by going after the beta-2 receptor. So now the heart is acting as a better pump and their airways are opened. Right, so there's conditions where you want that. Now, the last one is such a common set of drugs. A beta-2 agonist will cause bronchodilation. It's good for people with respiratory problems like asthma. And this is what this drug is primarily prescribed to, people with asthma, and that's albuterol. And I'll just give you the albuterol, but there's also terbutaline and other drugs that act the same way because there's different formulations. So my husband had asthma, not so much anymore. He has a rescue inhaler. I think I might have talked about this before. I can't recall now. And so when he was having an asthmatic crisis and he couldn't breathe and he'd wake up in the middle of the night, he would take his inhaler and give it a few minutes, and hopefully that would cause bronchodilation. He'd be able to breathe. Now, with that said, do you remember what I said about people using the rescue inhaler as the primary treatment for their asthma? Not good, right? The body builds a tolerance, and then the drug doesn't work after a while. And I watched that happen, and it's going to be terrifying. So anyway, you'll learn in nursing that it involves taking anti-inflammatories on a regular basis, and also some drugs. I've seen some commercials on TV that block the leukotriene or white blood cell inflammation pathway. So it's come a long way. So patients should not be living on the rescue inhaler. That's going to cause problems. But these are such common drugs, and they work by messing with those receptors that I've taught you. All right. All right. Any questions about those? Because I want to finish this chapter and move on. Okay. So a couple of slides after this. Now, I assume you had this from anatomy, but how the peripheral nervous system communicates with the CNS, the brain, spinal cord, and the rest of the body. So you learned and memorized them, I'm sure, in anatomy, the 12 pairs of cranial nerves. All right, I'm going to have you remember these as well because I mentioned them. Let me move this over here. All right, 11 cranial nerves are part of the peripheral nervous system. The optic cranial nerve is part of the CNS, so that's just a category. And then you learn the 31 pairs of spinal nerves: musculocutaneous, ulnar, radial, femoral, sciatic, all those nerves that you memorize that go to the muscles and make them contract. Okay, so you'll want to remember these mnemonic devices for the cranial nerves. Now remember, we've already talked about some cranial nerves. We talked about the vagus nerve, which is going to handle rest and digest functions of the body under autonomic nervous system. like the heart rate going down, your bronchioles constricting, your GI tract activity all going up. All that is the vagus nerve. It does so many other things. Okay, so what did you learn as a mnemonic device? Because this is what I learned for the order of the cranial nerves from 1 through 12, really from superior to inferior. O, once one takes the anatomy final, very good, vacations are heavenly. O for the O there, once one takes the anatomy final, very good, vacations are heavenly. Did you learn another mnemonic device? Is that the one? It's classic. All right. So if I asked you on a future lecture quiz, I'd say which cranial nerve stands for the vacations, and oh, once one takes the anatomy final, very good, vacations are heavenly. And so if you've learned this mnemonic device and you know that the very, whereas the vestibular cochlear comes before vagus, all right? Things like that. So I want you to remember that because I could ask that on a future lecture quiz. Now this one, did you learn it too? Which cranial nerve is exclusively sensory? And then they'll have an S in the mnemonic, which is exclusively motor, and we'll have an M. But some do both. The very big nerves, like the trigeminal and vagus and stuff, do both sensory and motor. And I found a mistake in this particular textbooks, so I fixed it here. All right. So some say marry money, but my brother says big brains matter most. So some, that's sensory, say sensory, marry, that's motor, money, that's motor. Trigeminal is a huge nerve, it does both, and so on and so forth. All right. I could ask you that. Which cranial nerve is both sensory and motor and stands for the brains? And some say marry money. So if you just, when you get that lecture quiz, you just list out all the cranial nerves in order, and then you remember the mnemonic, you'll have it down. All right, so that's actually review. Now, the last thing is review also. It's knowing that your spinal nerves, which are coming off the spinal cord, basically they merge past this point. All right, oh, go back. Past this point, sensory nerves and motor nerves merge. Okay, so when they become spinal nerves that come off the spinal cord, it's past this point. So the musculocutaneous spinal nerve, it does cause stimulation of the biceps and other muscles on that area to contract, but it's also taking sensory information from this region of the body and sending that up to the brain. When we do the balance test in today's lab, or this week's lab, you're going to appreciate the feedback you get from your muscles and your joints for keeping your balance. All right. Okay. So that's all I wanted to say about that. And the other thing is, do remember, because I could ask this on a future lecture quiz, the dorsal part of the spinal cord is all about sensory. All right. Sensory information goes this way and then goes into the spinal cord this way. Then it goes up to your parietal lobe or other places that are going to integrate and determine what the sensory information means. Motor, so sensory is dorsal. I lost my pen. There we go. Sensory is dorsal. And then motor is ventral. So if it's all about making skeletal muscles or other muscles contract or glands to secrete, information comes out the spinal cord in this direction and then goes out to the body in that direction. So that, I don't think you've got an anatomy, but that's important to know. It can always be more complicated, but I'm not making it more complicated. But it's called a bidirectional flow of information. Sensory is going up the spinal cord, motor's coming down the spinal cord. And I think this is just the same stuff, all right? The blue is sensory information. So sensory stuff goes in the backside of the spinal cord and then up to probably your parietal lobe. Motor information. Oh, I have the arrow in the wrong. Yeah, I have it going in the wrong direction. This arrow should be pointing outward. So I'll have to fix that. But it's coming out the spinal cord, out the ventral side, and out this way like that. And I think that's it. Oh. Yeah, don't worry about this part right here. I'm not going to ask that. Just the stuff I've covered before, right there. So that'll end of chapter 4, all of it. All right, that's peripheral nervous system. So we do have time today to get into the endocrine system, which is my favorite because I'm a reproductive physiologist and endocrinologist. So it's not everyone's favorite, but all the cool disorders are endocrine. They really are. Okay. So I'm going to escape this. I'll post it at least sometime today, as soon as I can. Okay. Then we'll go to the next PowerPoint. endocrine. Okay, some stuff, believe it or not, will be reviewed. Because you've learned some hormones already. You've learned oxytocin. You've learned it as positive feedback regulation. You've learned insulin and glucagon. You wrote a lab report on it. All right, so that's endocrine. So we're going to learn about some other things, but the big thing is your brain is in control of all your endocrine functions. All right, and your hypothalamus is going to be the one in charge of everything. We're then going to learn how the hypothalamus controls the anterior pituitary. The hypothalamus tells the anterior pituitary what to secrete. It's like a military hierarchy, and I'll go over that. And then, of course, end with some endocrine disorders, the ones you are absolutely definitely going to see on a regular basis because they're that common. Okay, so how many people in anatomy learn where the endocrine glands of the body are? It's kind of sad. Okay, we'll review it really quickly. So there's lots of them. The endocrine glands of the body, really the main one is the pituitary gland. All right, and that's up in your brain, hanging down from the hypothalamus, but it's the master endocrine gland. So this part right here is the thalamus, and then it's connected to the endocrine gland. And the hypothalamus is in control of everything. So if you think of a military hierarchy, the general is up here. The hypothalamus is the general. It's calling the shots, making the commands. Then the captain is the pituitary gland. It receives commands from the general, the hypothalamus. And then based on that command, the captain, the pituitary gland, will send out an issue or command to lower ranking officers or the endocrine glands of your body. They're the foot soldiers, all right? So that's what we're going to do, is we're going to spend a lot of time between the hypothalamus and the pituitary. The pineal gland, back here at the end of the diencephalon, anyone know what the pineal gland secretes? Especially at night? Melatonin, okay? It's supposed to help your circadian rhythm. Now, the adrenal glands, very important. There's a gland atop of each kidney, and there's a lot of cool common disorders you're going to see that are having to do with the adrenal glands, okay? So we'll get to that later. The thyroid gland is on the anterior of the trachea, and it produces thyroid hormones. Again, disorders of thyroid hormone are very, very common. They're so common, I saw these disorders in dogs and cats. It's common among all vertebrates. The parathyroid glands are located in the back of the trachea, and we'll talk about what it does. Now, your gonads, ovaries, and testes are endocrine in nature. They produce their own hormones. So what are the sex hormones that are associated with the ovaries? The main hormones that rule a woman's body. Estrogen and then progesterone, okay? And then in the testes, they produce testosterone, okay? Those are endocrine hormones that have a powerful effect. Your GI tract, the first hormones ever discovered were discovered in the GI tract. So it produces hormones. It's at the very end of the PowerPoint. Now the pancreas, you tell me. What is the pancreas secreting when blood glucose gets too high? Insulin, which tells your cells to take in glucose and then lowers your blood glucose. You got that down. And then when blood glucose is too low or glucose is gone, glucagon, which tells the liver to break down glycogen and release glucose into the blood to bring it back up. So you're familiar with that. So I feel we will skip right past that one. Okay, and then the liver produces some hormones as well. All right, we'll talk about that a little bit later. All right, so those were the quick review of endocrine glands. I don't think it's too bad if you've not seen it before. Okay, but this is the important thing. Here's how the endocrine system is controlled. Controlled by the general, all right? The hypothalamus. Now, I'm going to back out of this just for a second, and hopefully it stays there. Let me go back up to, for this chapter, the endocrine system, all right? So here's the wiki textbook, and that PowerPoint showed you this page. Most of the chapters that I cover in the wiki textbook, I only cover bits of it and I say, skip this part, skip this part, skip this part. This particular chapter, the entire chapter is what I cover. So I would read the whole thing, but if you scroll through, and I'll try and call them out in my PowerPoints when I have them, when I make when I make comments like, so when I have a table in my PowerPoint of what the hypothalamus can secrete, and then what the pituitary gland secretes, okay? And then the effect that happens on the body, This textbook does have a corresponding part to the tables I have. All right, so that's a good place to review. The textbook is very good for this chapter. And then some places here, like this I don't cover. So I say, we will not be covering this, so skip it. All right, so what I want you to skip it, I'll tell you. Skip all of that. Thank God, right? This you do want to have. Okay, there is. We will cover this in more detail in lecture briefly, blah, blah, blah. And then I go into more details. So when I have little comment boxes, look at that. All right, most of the chapter I'm going to want you to know. So it's a good chapter for endocrine system. All right, so let's go back to where we were. All right. Waiting for it to wake up. Okay, so the hypothalamus secretes neurohormones. So right up in here is the hypothalamus, and these clusters of neurons secrete a neurohormone. And those hormones, I'll circle it, I think I have it circled later, actually go down through the stalk of the hypothalamus and they go out the posterior pituitary. Posterior pituitary doesn't produce hormones. It just allows the hormones the hypothalamus produces out. So there's only two, and one of them we've talked about before. So the supraoptic nucleus secretes ADH. Let's get a different pen. ADH. I don't know if I've ever asked this before. Does anyone know what the ADH stands for? Anti-diuretic hormone. For water retention. This is how your body conserves water. This hormone allows your kidneys to, instead of letting out body water in your pee, you retain it and that water goes back into your bloodstream into circulation. So ADH is very important. And there's some disorders of ADH that you're going to encounter as nurses. Now the paraventricular nucleus, and believe it or not, we covered this back in the central nervous system, secretes oxytocin. Now you know what oxytocin does. Positive feedback. It's the milk letdown hormone when a child is suckling at the nipple. And it's the uterine muscle contraction hormone when the baby's head presses on the cervix. All right, so we covered that way back in chapter 1. So that's one function of the hypothalamus, is to control those things, which are very important. The other thing is, this is where we're going to be spending most of our time. The hypothalamus secretes releasing hormones. And I use an acronym of RH. There's going to be a letter in front of the RH, but this is what the hypothalamus secretes when it wants the pituitary to secrete something in response. This is the command where it says, hey, pituitary, I want you to secrete this hormone. This is my command. It's a releasing hormone. All right, so I'm going to cover 5 releasing hormones. There's more, but I'm just going to cover 5. And then when the hypothalamus wants the pituitary to not secrete something, it will secrete an inhibiting hormone. And I will teach you 2. There's more, but I think that's fine. And that'll be abbreviated IH. So if it says release, the pituitary is going to secrete something. If it says inhibiting, pituitary is going to stop secreting something. The balance of hormones in your body is so important. Remember when I was talking about neurotransmitters and I said, if you have too little of a neurotransmitter, you've got problems. If you've got too much of a neurotransmitter, you've got problems. Same thing with the endocrine system, all right? You will learn as nurses, because in a blood panel, you suspect someone's got Cushing's, adrenal cortex disorder, or you suspect they've got thyroid hormone disorder, hypothyroidism, hyperthyroidism. These disorders of the endocrine system are so common that your most general basic blood panel will automatically test for these hormones, all right? It'll test for things like ADH. It'll test for kidney function. It'll test for like blood urea nitrogen. It'll test for thyroid hormones, T3, T4, all right? It'll test for endocrine hormones and other things like that. Okay, now, lastly, the hypothalamus controls autonomic sympathetic secretion of epinephrine by your adrenal gland, the middle part called the medulla, or medulla, however you want to say it. Your hypothalamus controls your fight-flight response. Remember the 4 Fs? Feeding, fight, fornicating, fear, okay? That's your fight-flight system, and your hypothalamus is controlling that. All right, So hypothalamus does a lot. It's the general. It's got a lot of responsibilities. So I'll start with the 5 releasing hormones and the 2 inhibiting hormones. And we won't get to this entire pathway today, but we'll start it. So if you go to page 267 of the wiki text, I think that's where they have the table, but I make it much more straightforward. I always do. So the first thing the hypothalamus secretes are things that can affect your gonads. And I've got a couple of testes here. And that releasing hormone is called G, a little n, and then RH, which stands for releasing hormone. The GN stands for gonadotropin releasing hormone. And I'm not going to keep writing out the releasing hormone part because it's just too darn repetitive. It's going to go after your gonads, all right? Testes, ovaries. It's your gonads. But it's going to make the pituitary secrete something that will affect those gonads. All right, so GnRH, the GN stands for gonad, which are ovaries and testes. The other thing, too far, is growth hormone releasing hormone. So that stands for growth hormone. That one's easy. And I'm just going to put RH because I don't feel like writing the whole thing out. That's going to end up affecting all your body's tissues. All your body's tissues got receptors for growth hormone. Okay. Now, it's not secreting the growth hormone itself, but it's going to tell the pituitary to release the growth hormone. Now, the next thing is going to affect your adrenal glands. And it's going to affect the cortex, which is the outer part right here. So cortex of the adrenal glands. C for cortex of the adrenal gland, RH. So it's cortic for cortex of the adrenal gland, corticotropin releasing hormone. And you remember that the cortic means cortex of the adrenal gland. That's what it's going to go after. Now, after this, I've got the thyroid glands pictured. TRH. And the T stands for thyroid, thyrotropin releasing hormone. So if you look at the little bit of the word before, it'll tell you ultimately what it's going to affect. And then the last releasing hormone, I've got a picture of a mammary gland, is PRH, is prolactin, prolactin, that's an A in here, releasing hormone. The mammary glands won't make milk until it gets the signal of prolactin. Prolactin means prolactation. Lactation is milk production. The hypothalamus with this releasing hormone is going to tell the pituitary gland to release prolactin. Then the mammary glands produce milk. And we know that even when milk is made in those glands, it won't release it until it gets the signal of oxytocin, which also comes from the hypothalamus. Okay, so 5 releasing hormones. There's more, but that's plenty. Now, the inhibiting hormones, growth hormone is strictly controlled. So there's a growth hormone inhibiting hormone. And I'll just put IH for inhibiting hormone. It's also known as somatomedin. But I don't like that because that doesn't tell you crap. But if you say growth hormone inhibiting hormone, I know what's going to happen. Growth hormone. So with the Winter Olympics, I've been thinking about drug doping. Because, the Russian athlete got in trouble for taking something that was supposed to increase performance and everything. But you're going to see things as nurses. You're going to see people taking growth hormone. And you cannot get growth hormone that's FDA approved unless you get a prescription. So people who want to take growth hormone get it from unscrupulous sources, which means it's not regulated. Now, why would someone take growth hormone without a prescription? People who want to increase their athletic performance. It's sold in certain magazines, health magazines, bodybuilding magazines, to increase your athletic performance. It's also sold as an anti-aging hormone. Okay. Here's the thing. If you get a patient in and they happen to mention that they're taking growth hormone because of whatever, it could even be high school students. For athletic performance, some girls are taking it now because it causes more lean muscle to fat ratio. And so you can lean down. It's very dangerous. Okay. Your average run-of-the-mill person doesn't know these dangers. Growth hormone causes growth in all kinds of tissues. If you have precancerous cells in your body, that growth hormone is going to set it on fire. and your cancer cells are going to start dividing. That's danger number one. Number two, you've got a young person who's still growing. Their growth plates haven't fused. You're talking high school. People don't really stop their growth until their 20s. If they take growth hormone, yeah, their muscle mass will increase and everything, and they might get some increased bone growth, but their growth plates might fuse prematurely. They might put on so much mass quickly that their joints, which aren't mature yet, get damaged early and permanently. That's a problem. All right. So when I say growth hormone must be controlled very carefully, yeah. So that's something you might encounter. That's common enough that you might see it. All right. Now, the other inhibiting hormone is PIH. Come on, let me write that, which is prolactin inhibiting hormone. And that tells the pituitary to not release prolactin. So most adult women who've gone through puberty, their hypothalamus is secreting for most of their life this hormone, keeping the breast from producing milk. The only time that the hypothalamus stops secreting this and starts secreting this is when she's in her last month of gestation or just after the baby's born. When you milk up, that's because you've released the inhibition of this releasing hormone, and then you cause the milk production. And that keeps being released as long as a woman breastfeeds her child. All right. So that's a good introduction. Now, I'm going to stop here, but I'm going to give you a very applied things, very common. Most reproductive age women, like 99% of them, are on hormonal contraception to prevent pregnancy. Do you know how hormonal birth control works? I think as nurses you should, because kids come in at 12, they've got their period, you know. Okay, so here's how, you know, negative feedback, right? Something gets too high, you got to bring it down, right? Okay. If the testes and ovaries produce their sex hormones, a woman's ovaries produces estrogen and then progesterone, all right? If those hormones get too high, the hypothalamus will stop secreting this. It'll stop secreting GnRH because it says these hormones are too high in the blood. I've got to shut down the ovaries' production of estrogen and progesterone. And that's what would happen. Hormonal birth control works this way. Whether you take the estrogen, usually combined with a progestin, as a pill, a patch, an inject, an implant, whatever, NuvaRing, you take those hormones into your body over a little bit of time, a couple of months, depending on how you're getting it in your body. Levels of those hormones rise. They're synthetic hormones, but your hypothalamus can't tell the difference. It thinks estrogen and progesterone are rising. It will stop secreting GnRH. You'll find out on Wednesday, the pituitary stops secreting two hormones. One of those hormones, called FSH, causes egg maturation in the ovaries. And when the pituitary stops secreting FSH because of the hypothalamus shutting down, you stop maturing an egg every month. The pituitary will also stop secreting luteinizing hormone, which causes ovulation of a mature egg. Without luteinizing hormone, you don't ovulate. So hormonal birth control works this way. By negative feedback, the hypothalamus stops this, pituitary stops its hormones. In your ovaries, you stop maturing an egg and you certainly don't ovulate. Can't get pregnant if the egg doesn't leave the ovary. That's how it works, negative feedback. All right. So we'll get into that on Wednesday. All right. See some of you today in lab.